So that brings us to the end of my quick overview of food, diet, and lifestyle as part of the functional inflammology protocol. I'll pass through the following sections a bit more rapidly because we needed to establish a good, healthy, foundational diet and lifestyle. I just reviewed some of those components with you. I'm now going to discuss infection and dysbiosis. Then I'll talk about nutritional immunomodulation and dysfunctional mitochondria. So let's dive into the topic of infections and dysbiosis. I wrote a comprehensive review of dysbiosis in 2006. You can download that article for free. I also published a small book on the topic of human microbiome and dysbiosis in clinical disease in 2015, and this was later included in Inflammation Mastery in 2016. You can see here I also published a peer-reviewed article in the Annals of the New York Academy of Sciences titled Biological Plausibility of the Gut-Brain Axis in Autism. This, of course, focused on the role of gastrointestinal dysbiosis in autism. Also in 2016, I published this letter, Neuroinflammation and Fibromyalgia and Complex Regional Pain Syndrome is multifactorial. One of those important factors in the perpetuation of those conditions is gastrointestinal dysbiosis. My definition of dysbiosis is that it is a non-infectious, non-acute microbial colonization or exposure that adversely affects the human host. Again, my definition of dysbiosis: a non-infectious, non-acute microbial colonization that adversely affects the human host. Important concepts include the following. Subclinical infections are common in patients with chronic or sustained inflammatory diseases, especially all types of autoimmunity. We need to remember that the microbe alone is not the problem. We need to look at the patient's total inflammatory load and address that, as well as promoting immune defense and immune tolerance in order to reduce the consequences of that microbial colonization. Clinical assessments, laboratory tests, of course, are available, but obviously what is most important is the clinical response to treatment. Our therapeutic categories include antimicrobials, whether those are drugs or botanicals, immunorestoration, and what I call here functional immunomodulation or nutritional immunomodulation, and that is to enhance tolerance to inflammatory stimuli. Often what we find when working with autoimmune and inflammatory patients is that they're having a pathogenic inflammatory response to a non-pathogenic microbe. We see evidence for that in every single autoimmune disease. And we can also look at the classic prototypes of autoimmunity, such as reactive arthritis and short bowel syndromes, to appreciate the mechanisms and the cause and effect relationship between microbial dysbiosis and systemic musculoskeletal and vascular inflammation. Remember, we're not looking for classic infection here. We are looking to determine which underlying disruptions may be exacerbating inflammation and the patient's symptomatology. We have to look beyond disease-associated characteristics of the microbe to see the patient's individualized response to that microbe. Dysbiosis in one patient may present with dermatitis, while what appears to be the same microbial imbalance in another patient can present as peripheral neuropathy or inflammatory arthritis. Dysbiosis occurs in various locations throughout the human body, including the gastrointestinal tract, orodental cavity or the mouth and throat, sinorespiratory tract, parenchymal. So now we see evidence for microbial dysbiosis, for example, in internal organs, including the brain, genitourinary tract, cutaneous, which means dysbiosis on the skin, such as we see in patients who have eczema, and also environmental exposure to microbial molecules can also trigger systemic inflammation. Some of the microbes that we encounter commonly in clinical practice include Blastocystis hominis, Candida albicans, Citrobacter frunctii, Endolimex nana, Entamoeba histolytica, Gamma strep, Giardia lamblia, Halfnia alvei, Helicobacter pylori, which is connected with triggering migraine headaches, vasculitis, and also Raynaud syndrome, Klebsiella pneumoniae, classically associated with ankylosing spondylitis, Proteus mirabilis with rheumatoid arthritis, Pseudomonas aeruginosa with multiple sclerosis, Staphylococcus aureus with psoriasis and eczema, and likewise Streptococcus pyogenes with psoriasis. Here are some of the mechanisms through which microbes can create systemic or tissue-specific inflammation or autoimmunity. These include molecular mimicry, bystander activation, Th17 cell induction and suppression of T regulatory cells, also immune complex formation and deposition. You can see other mechanisms listed here, and you can see how those mechanisms work together in this diagram originally published in my book, Integrative Rheumatology, in 2006. So when patients have dysbiosis, let's assume a patient only has gastrointestinal dysbiosis. Well, that gastrointestinal dysbiosis includes many different mechanisms all functioning at the same time to promote systemic inflammation or tissue-specific autoimmunity. Obviously, I've continued to develop this work, most recently published in Inflammation Mastery 2016. Again, dysbiosis subtypes by location: gastrointestinal, orodental, cynorespiratory, parenchymal, including the brain, genitourinary, cutaneous, and environmental. Also, some microbes actually are hosts for other microbes. So the possibility exists that some microbes may be infected with smaller microbes. At the very least, we could use the example of bacteriophages infecting bacteria, and that one could have a dysbiotic inflammatory response against a microbe or the microbes within that microbe. And again, we do see some evidence for a correlation between bacteriophages and inflammatory bowel disease. So let me give you a concrete example from my own clinical practice. This is a 40-year-old white male with a 5-year history of idiopathic peripheral neuropathy. By the time he came to see me, he had basically given up hope, and of course, being a good naturopathic and functional medicine physician, I assumed that he had gastrointestinal dysbiosis. We performed a leaky gut test on him. We could see